Hello, this is Dr. Capper, and welcome to the Medical Cases in Plain English podcast. Welcome to the very first episode. So what inspired this podcast was a 1-month-long elective rotation that I did in Sonora, Mexico, where I worked in the ER and the ICU. And in preparation for that trip, I listened to a lot of podcasts in Spanish. What I found was that there was a general lack of podcasts that had good quality medical topics and medical information, but that were in clear, plain Spanish. So what I hope to do here is exactly that, but in English. I want to provide entertaining, high-quality medical information that'll be great for med students and residents in internal medicine, emergency medicine, but also that will be a great resource for any international medical graduate or somebody looking to get into the field of medicine that does not know English as their primary language. Now, the podcast will be divided into 4 types. That's as of now, at least. First will be board review type lectures, which will focus on internal medicine and emergency medicine board review topics, maybe cover a little bit of STEP exams as well. There'll also be cases, which will be interesting cases, how you should work up different presentations. This will have a slant towards critical care, internal medicine, and emergency medicine. There will be podcasts based on clinical pearls and podcasts based on knowledge pearls. Now, these will all be labeled. They'll be labeled board review or BR, cases, clinical pearls or CP, and then knowledge pearls as KP. So every time that you go to search a podcast, you'll know exactly what you're getting. Now, let's go ahead and get started with our very first lecture, which is going to be a knowledge pearl lecture on shock. Starting off with the 4 types of shock, and this is one that you should know fairly well. It's distributive shock, number 1. 2 is cardiogenic shock. 3, hypovolemic shock. And 4 is obstructive shock. You might also hear people talk about multifactorial shock, which I do think is good to think of as a possible 5th type of shock, at least for how you're thinking about these in a clinical sense. Now, with distributive shock, there's multiple different types and from multiple different causes. What you're going to see here on exam and pathophysiologically is vasodilation. You might see a patient that has warm extremities. They may be flushed, and they can also be tachycardic. The types of distributive shock include septic shock, neurogenic shock, anaphylactic shock, drug-induced shock, and toxic shock. A final category of distributive shock would be SIRS, or the Systemic Inflammatory Response Syndrome. So we know the somewhat antiquated now definition of SIRS, where you meet 2 out of the 4 SIRS requirements, those being a heart rate greater than 90, a body temperature either less than 96.8 degrees or more than 100.4 degrees, tachypnea with a respiratory rate greater than 20, or a white blood cell count less than 4,000 or greater than 12,000. So this is our classical definition of adult SIRS, meeting 2 out of these 4 SIRS criteria. As far as causes of SIRS, well, we're looking at non-septic causes, right? If you have sepsis, we're assuming that there is an infection causing you to meet these SIRS criteria. So things that can cause SIRS can be pancreatitis, a crush injury, an air embolism, fat embolism, an amniotic fluid embolism. All of these things, amongst many others, can cause you to have a SIRS response, which will in turn cause you to undergo distributive shock. So that's distributive shock. One last final little tidbit is a disease entity known as systemic capillary leak syndrome, or idiopathic capillary leak syndrome. This is an interesting clinical entity where you get leakage of your capillaries, as per the name, and you basically just extravasate or third space all of your fluid. all the fluid leaks into the interstitial space from the circulatory system. This results in hypotension, you get concentrated blood, known as hemoconcentration, and you also get hypoalbuminemia. So this is actually a life-threatening disease because you get poor perfusion to your end organs. Now, the attacks that patients get of this idiopathic systemic capillary leak syndrome seem to be triggered by some sort of infection, whether it be an upper respiratory tract infection or another source. And the prognosis is okay. About 70% of the patients, after they survive the initial attack, they are alive after 5 years. So a 5-year survival rate of about 70%. Next up is cardiogenic shock. So cardiogenic shock can be caused by a couple different things, and it's typically divided up into 3 categories. There's cardiomyopathic cardiogenic shock, arrhythmogenic cardiogenic shock, and then finally mechanical cardiogenic shock. Typically, patients in cardiogenic shock are going to have vasoconstriction. They might have tachycardia, they can have dysarrhythmias, and they can also have altered mental status. Now, I want you to contrast this vasoconstriction of cardiogenic shock with the vasodilation of distributive shock. For example, in distributive shock, septic shock, patients have vasodilation secondary to bacterial toxins inducing this vasodilation. Now, a person in cardiogenic shock has a normal functioning compensatory mechanism for poor tissue perfusion or low blood pressure. This normal compensatory mechanism is vasodilation. There are actually 3 different categories of cardiogenic shock. They are cardiomyopathic cardiogenic shock, arrhythmic cardiogenic shock, and finally mechanical cardiogenic shock. Cardiomyopathic cardiogenic shock, this is your typical myocardial infarction or some other sort of occlusion that causes a patient to have poor cardiac function. This is normally secondary to ischemia. This is opposed to arrhythmic cardiogenic shock, where an arrhythmia causes a patient to have poor cardiac output. Now, this could be a tachyarrhythmia, such as VTach. Of course, VFib would cause poor cardiac output, but it can also be a bradyarrhythmia that induces hypotension and shock. For example, simple sinus bradycardia could cause this. Finally, you have the mechanical causes of cardiogenic shock. These include mitral valve insufficiency, such as valve rupture or papillary muscle rupture or chorda tendineae rupture. It could also be secondary to dissection of the aorta. So dissection of the aorta, for example, if it's a retrograde dissection or a ascending dissection, this can cause dissection all the way up into the aortic valve ring, and that will stop cardiac output. Also, abscesses in the aortic ring can also result in aortic insufficiency. So those are the 3 subtypes of cardiogenic shock. Now, we talked about distributive, cardiogenic. Let's move on to hypovolemic shock. This is divided into 2 categories. The 2 categories of hypovolemic shock are hemorrhagic versus non-hemorrhagic. When you think of hemorrhagic hypovolemic shock, what is the first thing that you think of? Well, normally we think of trauma, but this can also be caused by a bleed of any other source. For example, a peptic ulcer, a variceal bleed, sometimes even a diverticular bleed can cause this. Less common causes of hemorrhagic shock can be intraoperative or postoperative bleeding, a ruptured aortic aneurysm. Anything that can bleed can cause hemorrhagic hypovolemic shock. Now, the second type of hypovolemic shock is actually non-hemorrhagic. Makes sense, right? First type is hemorrhagic, second type is non-hemorrhagic. And this is from reduced intravascular volume from fluid loss other than blood. So anything that causes fluid loss other than bleeding can cause Non-hemorrhagic hypovolemic shock. This includes GI losses, for example, diarrhea, nausea, vomiting. Skin losses, such as heat stroke, burns, can lose very large quantities of fluid, and you can also lose fluid through the kidneys, such as excessive osmotic diuresis or salt-wasting neuropathies. And finally, you could third space into the extravascular space or body cavity secondary to crush injury or pancreatitis. This is kind of similar to a distributive type of shock, wherein you have the correct amount of fluid in your body, however, it is not distributed to the right place. For example, it's in the third space, or it's extravascular when it should be within the vasculature, or intravascular. Finally, we have the last cause of shock, which is obstructive shock. Obstructive shock actually has some fairly interesting diagnoses associated with it. These include tension pneumothorax, pericardial tamponade, constrictive pericarditis, and also restrictive cardiomyopathy. The one type of obstructive shock that you may have noticed I didn't mention is a pulmonary embolism. Now, pulmonary embolism is my favorite cause of obstructive shock because it actually has an interesting pathophysiology behind it. Whereas you might initially think, oh, what's going on here? Well, we have a blood clot. It's in the pulmonary arteries, and it's causing a decrease in blood flow from the right side to the left side of the heart. Well, what's actually going on is a little bit more complex. Yes, there is some aspect of decreased blood flow. Of course, you're putting a clot inside the pulmonary arteries, and that's going to decrease right ventricular output. But it also can cause pulmonary hypertension. So in a normal patient, once about 25 to 30% of the pulmonary vasculature is occluded by clot, then you can start seeing pulmonary artery hypertension. And what this is elevated pressures in the right side of the heart and the pulmonary arteries. So there's a couple things causing this. One is the clot itself. The decreased blood flow that it causes across the pulmonary arteries causes blood to back up to the right side of the heart. But also, you get a local hypoxia, a decreased amount of oxygen wherever the clot is, and that causes pulmonary artery vasoconstriction. So you have these couple factors in play causing elevated pressures on the right side of the heart. So why do we care then about these elevated right-sided pressures? Well, they're related to a concept known as intracavitary pressure, or the pressure inside a cavity. Specifically, the right ventricle is what we're talking about here. These elevated intracavitary pressures, or right ventricular pressures, they can have a really bad effect on the actual myocardium itself. So we know that the left ventricle, well, it can sustain high pressures, right? It's made of thick myocardium and it's arranged in a circular manner. Well, the right ventricle, shaped more like a crescent, it's made of thin myocardium. And when you get really high pressures, it causes actual dilation of the right ventricle. And what does this dilation do? Well, it can actually damage the sarcomeres of the myocardial muscle itself. On top of that, it causes a local ischemia, a subendocardial ischemia. Now, why is this? Well, the coronary arteries, we know they penetrate from the outside in, from the outside of the heart to the subendocardium. And if you have high intracavitary pressures, high pressures in the right ventricle, it actually stops this blood, the blood from the coronary arteries, from being able to penetrate deep down into the subendocardium. This then causes decreased RV output and eventually leads to right-sided heart failure, which eventually causes death. Furthermore, that's why you're going to see these elevations of BNP, or an elevation of troponin, in a pulmonary embolism, both of which, by the way, increase your mortality. They are a risk factor for poor outcome. A elevated BNP is a sign of right ventricle and right-sided heart dilation, and an elevated troponin is a sign that there's actual heart muscle damage caused by that pathophysiology I had just mentioned before, where you get decreased blood flow to the subendocardium. So if you have a patient with a pulmonary embolism that has elevated BNP, or they have a elevated troponin, it might be worth it to take a look at their heart with the ultrasound and look at the RV to LV ratio. And that's all I have for you today. I hope you enjoyed the first podcast. I'll try to keep labeling them, whether the podcast is one of the 4 topics. Remember, they were knowledge pearls, clinical pearls, board review, and then finally cases that I might have seen at work or heard from colleagues of mine.